person, Professor Dr. Sri Gopal Goyal, Department of Psychiatry, SP Medical College, Bangaluru, Rajasthan. And today's speaker, Professor Dr. Jagadisha, Department of Psychiatry, NIMHANS, Bangalore. And today's moderator, Dr. Vasugi, Consultant Psychiatrist of our Sneha Main Care Hospital, Thirthalli. My dear colleagues, practicing for psychiatrists, postgraduates, a very good morning to all of you. I want to extend my warm welcome to all of you. Indeed, it's a great privilege for us to organize this event. And today's speaker, Dr. Jagadisha, Dr. Jagadisha is a very close friend of mine and he's my MD batchmate at NIMHANS. Dr. Jagadisha is going to speak about the balancing evidence and practice of ECT. He's an ideal person to talk about the ECT because Dr. Jagadisha has done an extensive research on ECT and he has published numerous research paper on ECT. Hope this topic will definitely helpful for the postgraduates and also for the practicing psychiatrists.
Thank you, sir. I welcome everyone joining us today for this Evolve lecture series. We appreciate you taking time to be here with us today. Myself, Dr. Vasugi, currently working as a consultant psychiatrist in Sneha Mind Care Center. And I welcome our chairperson, Dr. Sri Gopal Goyal, sir, our esteemed speaker, Dr. Jagadisha Thirthalli, sir, and our course director, Dr. Pani Selvan, sir, whose perseverance and broad vision keep this series a great success. Let me introduce our chairperson today. Dr. Sri Gopal Goyal, sir. Sir has done his MBBS from Sardar Patel Medical College, Bikani, MD from All India Institute of Medical Sciences, New Delhi. Sir has more than 10 years of teaching and research experience. Currently, sir is serving as a professor and head of the Department of Psychiatry in Sardar Patel Medical College, Bikaner. Now, I request our chairperson, Dr. Sri Gopal Goyal, sir, to introduce the topic of today's webinar. Over to you, sir.
Thank you, madam. Thank you to all respected sir for including this important webinar. As we know that electroconvulsive therapy is one of the most important modality of treatment in the psychiatry. It occupies unique position in psychiatry practice, while it is a first of choice of treatment and life-saving in the patient with a high suicidal risk. It is also prescribed in a situation where other treatment methods have failed. It is also one of the oldest physical method of the treatment which have stood the test of the time. It is likely that 1938 Italian physician Sarletti and Bini may not have envisioned the massive impact of ECT was on next 85 years. Despite the long history, ECT still remains a topic of debate among the mental health professionals, patients, and the families. While some view ECT as a life-saving, others raise concern about the safety and the potential side effects, such as memory loss and the cognitive impairment. Recent advances in the ECT technology and the technique have improved its safety profile, but the treatment effectiveness vary widely depending upon the individual patient's circumstances. As we navigate the complex landscape of mental health treatment, it is essential to strike balance between the evidence-based benefit of ECT and the practical consideration of its application in real-world setting. I hand over to our esteemed speaker, Dr. Jagadisha Thirthalli, sir, for presentation.
Let me introduce today's speaker. I welcome Dr. Jagadisha Thirthalli, sir. Sir is currently working as a professor of psychiatry in National Institute of Mental Health and Neurosciences. Sir did his MBBS from Mysore Medical College and MD Psychiatry from NIMHANS. He is a faculty in NIMHANS since 2002. Sir has over 325 published papers and contributed more than 20 book chapters. His research interest includes neuromodulation, RTMS and ECT, and long-term outcomes of severe mental illnesses in the community. Sir has been a principal investigator and co-investigator of 40 funded projects, and we are privileged to have you here, sir. With this short introduction, I request Dr. Jagadisha Thirthalli, sir, to enlighten us today. Over to you, sir.
Yes, thank you very much. Without wasting more time, I will straight away delve into today's topic, ECT balancing evidence and practice, because what we read in most of the articles is what the so-called West or the global North publishes. We in India are part of global South, are a developing country, and particularly in India, ECT practice is very different. Like you can see this, there have been surveys done of ECT in India and in Asia. What we see is that mostly the people who get ECT in India are predominantly men, relatively younger people between 18 to 50 years of age. We give a lot of ECT to people with schizophrenia more than depression or other indications. Most commonly used electrode placement is bilateral, and we hardly use EEG monitoring. This is in contrast to what happens in most of the Western countries, where the ECT is predominantly given to women who are of older age group. Mostly, nearly 90% of them have depression. Most often used electrode placement is unilateral, and almost all the time EEG monitoring is done. So the practice in the West and India are very different. About 15-16 years back, we made a direct comparison of the practice of ECT between Maudsley, London and NIMHANS, Bangalore. The differences are very stark. As I said, Bangalore patients are relatively young. About 50-50 of them are men and women, whereas 70% of patients in London were female. Mostly the percentage of patients who are admitted who received ECT were about 8% in NIMHANS and hardly 1% in London. 89% of the patients had depression in London as compared to 2.2% in schizophrenia, whereas nearly 40% of each had depression and schizophrenia in NIMHANS. There were none who had catatonia in the London sample, whereas 7% of NIMHANS sample had catatonia. So I'm trying to, I'm here by giving you the reason why I have chosen this topic, that is evidence and practice. What evidence we generally get in most of the journals is from the West, whereas the practice in India is very different. So basically, I'm making a point that ECT practice is different in India. So with this, the overview of today's presentation, I will not be talking everything about ECT. I'll choose a few topics which are mostly relevant in the past 1 decade of development of ECT. The older literature is very much there for everybody to read. Recent trend in ECT for depression would be Ultrabrief-pulse ECT and the use of ketamine, how ketamine compares with ECT. What is the evidence for ECT in schizophrenia? And finally, about cognitive adverse effects of the ECT. We can have some time for discussion. Okay. Now, with this, I will come to the details about the Ultrabrief-pulse ECT. Now, you see that the difference between, this is how a typical ECT stimulus works. There are positive and negative pulses in either direction. So each pulse is wide by about 0.5 to 1.5 in brief pulse ECT. Whereas when it comes to ultra-brief ECT, it will be less than 0.3 milliseconds. So why people are choosing more and more ultra-brief ECT is because the time required for a pulse to elicit an action potential, that is the Chronax C, is about 0.1 to 0.2 milliseconds. So anything beyond 0.1 to 0.2 milliseconds is not going to have any effect on the action potential. So why unnecessarily use broader pulses? So this much is enough to elicit action potential. Why should you give so much? So that is the reason why people suggest that we should go for ultra-brief ECT. Now, how does it matter at the tissue level? We have understood the physics of it. Now, when it comes to the tissue level, as compared to brief pulse ECT, ultra-brief ECT causes about 14% less axonal depolarization and 4 times less axonal or somatodendritic depolarization. It also covers less areas of the brain as well as less neuronal tissue which is getting affected. Now, how does it matter clinically is the question that clinicians will ask. We have talked about physics of it. We have talked about neurobiology of it. Now we'll come to the clinical aspects. Now, there have been many systematic reviews, but this may be the one which has covered the most. It has covered 6 studies comparing unilateral ultra-brief ECT and brief pulse ECT in 689 patients. There is a consistent evidence that ultra-brief pulse ECT is much better than brief pulse ECT insofar as cognitive superiority is considered. When you look at cognitive impairment, so you can see all these diamonds are on the left side, which is favoring the ultra-brief ECT, which is suggesting that it is cognitively better. But it is also clear that for some reason, it is of slightly less efficacy than the brief pulse ECT. Here you can see that when you look at the standardized mean difference, or you can look at the percentage of people who experience remission. So brief pulse ECT seems to be better than ultra brief pulse ECT. So what is very clear is that ultra brief ECT takes about 2 additional ECTs to achieve similar outcome. So ultra brief pulse ECT is better cognitively, but it takes about 2 additional ECTs to reach the efficacy of the brief pulse ECT. Any clinician will know that if there is an urgent need to improve, we need to go for the efficacy, not so much about the cognitive adverse effects. So they have also studied what happens to their practice when they have introduced ultra-brief ECT in routine service, and it again is consistent with the observation from controlled studies that even in practice, it is observed that the introduction of ultra-brief ECT in routine service resulted in about 2 additional ECTs in general. Overall, the summary is, if urgency of response is required, then go for brief pulse ECT. If the cognitive safety is concerned, go for ultra-brief pulse ECT. So this is the take-home message about ultra-brief ECT. But you should also have other considerations. Now, bilateral ultra-brief ECT is much poorer efficacy, has much poorer efficacy, as I showed in that MCQ. Depression constitutes about 40% of all ECTs in India, and unilateral ECT is poorly suited for indications other than depression. So 60% of the patients receive ECT for indications other than depression. And unilateral ECT is not very well suited for indications other than depression. It has hardly been studied in indications other than depression, unilateral ECT. But bilateral ECT is a default treatment in schizophrenia, mania, catatonia, etc. Right? Now, substantial proportion of patients who receive ECT for rapid control of symptoms and bilateral ECT is commonly used when you need rapid improvement. So ultrabrief ECT may be considered only in select cases because bilateral ultrabrief ECT is poorer in efficacy. So I hope I have made my point clear that because the practice in India is predominantly A, for rapid recovery, B, for indications other than depression, and the evidence that you see in the literature is mostly for depression and with unilateral ECT. So given all these things, one should be careful while choosing ultrabrief-pulse ECT, not just going by the evidence, but you should see how it applies to your practice, whether you are using unilateral ECT or bilateral ECT, whether you are giving ECT for saving the cognitive adverse effects or for making the patient better soon, or whether you are giving it for indications other than depression. Now I'll move to the next topic, ketamine versus ECT and ketamine with ECT. First, ketamine versus ECT. Now, ketamine has become very popular treatment for depression. Specifically, ketamine likely has faster onset of action and seems to have specific anti-suicidal effect. Both are very similar to ECT. Now, how does ketamine compare with ECT in depression? Okay, now there has been a meta-analysis by Vikas Menon and colleagues from JIPMER, which was published last year. They have reviewed 5 trials in this systematic review and have shown that ECT seems to be better than ketamine in terms of efficacy. Right? They have remarked that most of the 5, 3 had poor quality. They chose only 2 of good quality. This also shows that the efficacy of ECT is much better than the ketamine. 2 studies. This study, the Escaron et al. Study, I will take it up in one of my further slides, but I just want you to know that the Sharma et al. Was an MD thesis done in NIMHANS, which again showed that ECT is better than ketamine. So higher response and remission rate with ECT and similar speed of response and remission with ketamine and ECT. Now, there has been one more large study after this review was published. This is the called ELECT-D study. Here, the remission with ECT was found to be 21%, whereas with ketamine it was found to be much higher. The response was also much higher for ketamine. The conclusion was ketamine is non-inferior to ECT. In other words, ketamine is either equivalent to ECT or even better than ECT. Now, we have this Exterand et al. Study, which has a large sample size of 91 and 95, which shows that ECT is better. This is again a large study which shows that ketamine is better. Now there is a problem with this. 2 large studies, both are RCTs, both show results in the opposite direction. The authors of this particular study have responded after this next study was published in another paper. Extrand et al. Have written another paper after this study was published, and they showed that there were many differences between their paper, which is ECT study, and the other study, which is ELECT-D study. The differences are here. ECT study had only inpatients, whereas the ELECT-D study had 90% outpatients. Older patients were there in ECT. Psychotic depression was 17%. They were excluded in the ELECT-D study. The duration of treatment depression was briefer in their study. It is much longer in the other study. Anxiety comorbidity was hardly not there, and nearly 50% of the patients had anxiety in the study that showed ketamine to be either equivalent or better. Number of ECTs were also slightly longer in their study, and the type of ECT, most importantly, is brief pulse right unilateral or bitemporal ECT, whereas this ELECT-D study used ultrabrief-pulse right unilateral ECT. And the overall response and remission with ECT was much higher in ECT, whereas it was 41%, or remission rate was only 22% in ELECT-D ECT. What they are saying, what the authors of the first study, which showed that ECT is better, are implying here is that their patients were more representative of more severely ill psychotic depression patients who received more efficacious method of ECT, and their response and remission rates are in sync with what is known in ECT literature. Whereas the study which showed that ketamine is equivalent to ECT or better had very unusual sampling. Most of them were outpatients, mildly ill, had a lot of anxiety, comorbidity, which is not a good sign for ECT, and they used the slightly lower efficacious treatment among the ECT treatment. Not surprisingly, only 22% had remitted, which we don't find in ECT literature. What we find in ECT literature is remission rates are generally 50% or more. This is the explanation that they gave, saying that if you choose very patients who are highly in need of ECT, then ECT seems to be better than ketamine. Though ketamine may be slightly inferior to brief pulse ECT in patients where ECT is indicated. Example, inpatients and psychotic symptoms. But ketamine may be considered if cognitive effects are a major concern, especially if the need for rapid response is less acutely felt. Okay, so this is the verdict as of today on the comparison between ketamine and ECT. Now, ketamine is also used as an anesthetic agent for ECT, and there are 4 meta-analyses where they have analyzed, they have ketamine versus another anesthetic agent. What you can see is that each study has been, each meta-analysis has come out with diverse findings. So overall, there is no consensus whether ketamine anesthesia is better than other anesthesia. You can also note that most of the studies are consistent in one aspect, which is adverse effects are more when ketamine is used as an anesthetic agent as compared to other anesthetic agents. So efficacy wise, there is no consensus. Adverse effects wise, there seems to be some consensus. So what you can think is that there is some doubtful clinical benefit of using ketamine anesthesia for ECT, because ECT itself has robust effect. Little extra is gained by using ketamine as an anesthetic agent, and possibly has an advantage early during ECT course, but not later. Seizure threshold lowering effect may be helpful, but adverse effects are an important concern. So ketamine can be used as a load at a lower dose, and lower dose of other anesthetic agents can be used. For example, ketofol is a combination, ketamine plus propofol, both at lower doses. What that kind of combination does is it lowers the rate of adverse effects of ketamine, and it is helpful to reduce seizure threshold. This can be used. So adding ketamine to ECT anesthesia may not add to clinical efficacy of. Move to the next one, ECT in schizophrenia. Why ECT is important for schizophrenia? Probably more patients with schizophrenia receive ECT than those with depression. if you look at what percentage of patients that receive ECT do so for schizophrenia, you will find very interesting results. In Europe, among all patients who receive ECT, only 5% have schizophrenia. In France, it's about 20%. But when it comes to Russia, it's about 80%, 85%. If 100 patients receive ECT, 85% of them will have schizophrenia. In Asia, it is about 40% in India, 70% in Thailand, 65% in Japan, and overall Asia, it's about 47%. So you can also see that across continents, there are vast differences, right? So what I'm trying to summarize in terms of summary, USA and UK and some Western European countries, the percentage of patients who receive ECT who have schizophrenia is about less than 15%. Whereas in Eastern Europe and most of Asia and Africa, it's about 40%. So in most populous regions of the world, which includes India and China, nearly half of the patients who received ECT do so for schizophrenia. So I can easily prove the point that among all patients who receive ECT in the world, most patients seem to have schizophrenia. Now, if you look at what is the research of ECT in schizophrenia as compared to ECT in depression, you will find this is an analysis that we did sometime back, about 15 years back. We did a bibliographic analysis of published data using the PubMed database in terms of ECT. We just searched all papers on ECT for the duration between 1979 and 2009, and we looked at the English language literature. What we found is that there were, of the 829 research papers, 65% were on depression, only 8.5% were on schizophrenia. Right? So it's a massive difference in the, this is the original papers, these are case reports. So what we can easily prove is that while most patients who receive ECT do so for schizophrenia, there is a significant, a nearly 8-fold increase or 8-fold more research is happening with depression than with schizophrenia. So this is the, there is a vast difference in the practice and literature. So Tharian and Adams have done a systematic review of ECT in schizophrenia. They have suggested that ECT is better than sham ECT, and antipsychotics are better than ECTs, and antipsychotics plus continuation ECT is better than either alone. The author's own conclusions were, which is not exactly found in the literature, I mean the review, systematic review itself. Their conclusion is that there is limited evidence to suggest that ECT combined with antipsychotics result in greater improvement. ECT combined with treatment with antipsychotics may be considered as an option, particularly when rapid global improvement is required. Unfortunately, they did not give any data to support this. Also, for those who show limited response to medication, and they have concluded that there are many unanswered questions regarding its role in the management of schizophrenia. Now, in our practice, we hardly give ECT without antipsychotics. Almost all patients of schizophrenia who receive ECT do so when they are on antipsychotics. Now, the question is whether ECT plus antipsychotic is better than antipsychotics alone. Now, in this review of the Cochrane review, there were 12 studies which compared ECT plus antipsychotics versus antipsychotics alone. And there were equal number of studies which showed that antipsychotics plus ECT is to be better than or comparable to antipsychotics alone. There was 50-50. 6 studies showed that ECT plus antipsychotic is better, and 50% of them, 6 studies showed that there was no difference. A common indication for ECT in schizophrenia is need for rapid improvement. Okay. In 9 studies, the speed of response was studied. And here, 6 studies showed that ECT is resulted in faster onset of action. 3 studies did not show that. The review did not meta-analyze the speed of response. So there was no firm reason to conclude whether speed of response is hastened by ECT or not, which is what we have been doing. We are using the same data and we are now doing a meta-analysis. We have done a meta-analysis of speed of response to ECT plus antipsychotics versus antipsychotics alone in schizophrenia, which is not yet published, but we have registered our meta-analysis in a registration. I mean, in the Prospero meta-analysis registry. We have this is the search strategy that we have used. So we have taken 24 full text studies and did this meta-analysis. If you look at the results, there is no difference between ECT versus ECT plus antipsychotics versus antipsychotics alone in the first week. But in the second week, there seems to be some trend towards better improvement in ECT. There isn't much in the third week, but in fourth week, ECT plus antipsychotic is better than antipsychotic alone. You can see that in almost all, ECT is better than the antipsychotic group, but it is reaching statistical significance in the second week and fourth week. The reason is nothing to do with whether ECT is less useful in the first ECT or third ECT. The reason why the difference is missing the statistical significance is because there are less number of studies which have analyzed in the first ECT and third ECT. So, as you all know, as the sample size increases, the clinical significance, the statistical significance also improves. That is why in fourth week, there are so many studies and it is showing as ECT to be better. So week 5, week 6 also we have done very less number of studies. Okay, you look at this graph. If you look at the graph on your right, you can see that the ECT plus antipsychotic group is showing rapid improvement in the first week and second week and sustains it over the period of time. So overall, it appears that from this meta-analysis, there is an advantage of ECT plus antipsychotic over antipsychotics alone in terms of speed of response. So a student of mine last year asked this question: does ECT reduce hospitalization duration? Is it helpful to give ECT early in the course of hospitalization? So we analyzed the data of 468 inpatients who received ECT. The early ECT correlated with earlier discharge across all diagnoses. You can see this is all diagnosis. This is for non-affective psychosis. This is for depression. This is for mania. The earlier you start ECT, the earlier you discharge the patients. So this is the gist of this retrospective analysis. As with all studies, we cannot infer causality from a correlation analysis. We have also done a study comparing speed of response of bifrontal versus bitemporal ECT in schizophrenia, and we have shown that bifrontal ECT is better in efficacy in BPRS, nurses' observation of schizophrenia, and catatonic Cochrane rating tool. And also, bifrontal ECT seems to be cognitively safer than bitemporal ECT in 14 out of 21 cognitive tests that we have done. Now, what about ECT in treatment refractory schizophrenia? All these studies were done in many other, there was a bunch of patients who were treatment resistant or not. Now, what is the answer of role of ECT in treatment refractory schizophrenia? In this Cochrane review, 15 studies were analyzed. 1,285 patients were there with treatment-resistant schizophrenia. They were symptomatic functional and cognitive outcomes were studied. What it showed was that ECT plus antipsychotic versus antipsychotics alone, there were 12 studies. The response was higher among ECT patients. There were higher rates of memory impairment also in ECT patients. But we need to be very cautious while interpreting this. That is because there was only one study which used sham ECT. All other studies, there was no sham ECTs. And you know that if you do not use sham ECT, there can be some bias in the analysis of the results. So in this study which used sham ECT, there was no difference between ECT and sham ECT. We should be cautious while interpreting these results also because 14 of the 15 studies that were included were rated as high risk of bias in terms of blinding, allocation concealment, and whether they used intent to treat analysis or not. So critical aspects of blinding and allocation concealment were compromised in 14 of the 15 studies. So it is still difficult to say that adding ECT to a person with treatment refractory schizophrenia has good evidence of use. You should also note that 12 of the 15 studies in that meta-analysis came from one country, that is China. I have nothing against China, but it is difficult to ignore the fact that most studies came from China only. So the authors concluded that the available evidence was too weak to indicate whether adding ECT to standard care is superior or inferior to adding sham ECT or other antipsychotics to standard care. Now, there is one latest study from India which has given some hope. Here, 60 patients were randomized to receive either acute plus maintenance ECT or Clozapine. So they were treatment refractory schizophrenia. So our first response in such cases is to give Clozapine. Now these authors from AIIMS Bhubaneswar compared whether we should go for Clozapine or we should go for acute course of ECT while continuing the same antipsychotics and then put them on maintenance ECT. They did a wonderful follow-up for about 24 weeks. What it showed was that ECT was much better than Clozapine. ECT in all instances of assessment, Clozapine was found to be inferior to ECT. Now, for the first time in the history of psychiatry, these authors suggest that there is a treatment which is better than Clozapine for treatment refractory schizophrenia. It is such an important finding that for the first time somebody is saying that we have found some treatment which is better than Clozapine for treatment refractory schizophrenia. Hence, the implications of this study should be carefully analyzed and only then we should think whether it is better or whether this can be concluded or not firmly. So we responded to this paper highlighting some of the methodological problems in their paper. There are many potential biases. There was no participant blinding. The patients knew whether they received ECT or Clozapine. Now you know that any procedural treatment versus medication, there is a high placebo response in procedural treatment. So there is a possibility that people who knew that they are going to get ECT had a higher placebo response. There is a distinct side effect profile between ECT and Clozapine. Now the raters were blinded in this study, but anybody who has interviewed a patient who has received ECT versus who has received Clozapine the rater will be able to easily assess whether this patient received ECT or Clozapine. Now, an ideal trial would have been where the rater should be asked, can you know whether this patient received ECT or not? And that will give you a sense of how good was the blinding. That procedure was not done, so we do not know whether blinding of the rater was also compromised in this study. The study did not mention anything about allocation concealment. All of us know that allocation concealment is an important step in RCT, so there seems to be some potential bias in allocation concealment. And combination therapy in ECT arm was there, whereas only Clozapine monotherapy was given in the other. The ECT team, ECT patients got antipsychotics plus ECT, whereas the Clozapine treatment, the arm got only Clozapine. So these were some potential biases were there. We should also know that even if Clozapine is found to be inferior or ECT is found to be superior to treatment resistance, the question comes as to what happens in the long run. After 6 months, after 1 year, will you continue to give ECT? Anyway, you will have to give Clozapine one or the other day, right? So the question comes whether just because ECT is better, can we give all patients with treatment-resistant schizophrenia ECT alone? This question we need to ask. So ECT in treatment-resistant schizophrenia has been seen very skeptically by the Royal College of Psychiatrists. What they say is that claims for the efficacy of ECT in treatment-resistant schizophrenia would perhaps be best described as triumph of anecdote over empiricism. What this sentence says is that we need better evidence before we say that ECT is useful in treatment-resistant schizophrenia. Hence, right now, we are doing a clinical trial taking care of all the previous bias, previous methodological challenges. We are currently doing a trial where we are randomizing 100 patients with Clozapine resistant or intolerant patients. They are not just treatment resistant schizophrenia patients, they are Clozapine resistant patients. They will be randomized to either receive true ECT or sham ECT with a triple blinding technique. The blinding assessment will be done and allocation concealment will be ensured and clinical and neurobiological effects will be studied. We are awaiting the result of this study to know whether ECT is better in Clozapine. Now, final topic of my presentation will be cognitive adverse effects. There has been a very good meta-analysis done by Semkowska and McLaughlin. So what they found is that compared to baseline, what happens to cognitive functions after 3 days of ECT, 4 to 15 days of ECT, and 15 days after ECT. All the red ones are significant findings. If the symbol is minus, that means compared to baseline, there is worsening of cognitive impairment. You can see that there are so many red and bold numbers in the 0 to 3 days column. That means compared to baseline, there is a significant cognitive impairment within 0 to 3 days. But what is more interesting is what happens after 4 to 15 days and after 15 days. There are many red numbers here which suggest that compared to baseline, there is a significant change, but that change is in the positive direction. Except here, all others are in positive direction. What it means is that most of the cognitive functions actually show substantial improvement with ECT. The worsening is found only in the initial few days, right? These are a few more cognitive functions here. So the same story here also, minus in the acute phase, and if you give more time, people tend to do better than their premorbid self. So most cognitive domains showed improvement, worsening in the first few days, nearly all improved within 15 days, and most were significantly better, and none was worse than the pre-ECT by 15 days. So the summary is that ECT actually causes impairment only in the initial few days, but once you give more time, it improves. But the problem with this is that there is an important cognitive assessment, that is retrograde memory, was not included in this analysis. They have taken only in depression. They have not taken in schizophrenia. So what happens in schizophrenia? We had an opportunity to study this in a cohort of our studies. I told you that we did an RCT comparing bifrontal and bitemporal ECT. We followed these patients up, irrespective of whether they received bifrontal or bitemporal ECT. We followed them up and looked at their cognitive functions 3 months after the ECT. That is, about 50 patients were followed up, right? What we saw is that in all aspects, by the follow-up of 3 months, the cognitive functions were far better. They had improved as compared to baseline during follow-up. As compared to baseline means at the end of ECT course, there was a substantial improvement. You can see HMSE, for example. At the end of ECT trial, their HMSE was 23. At the end of 3 months, it is nearly full, that is 30 out of 30, right? So all patients had improved substantially at the follow-up period in all the tested domains. There have been some more recent meta-analysis which have found that, which have studied 91 studies, 3,000 plus individual patients of all diagnoses. And they compared baseline scores, that is pre-ECT scores, with within 24 hours of last ECT, 1 to 28 days of after last ECT, and more than 1 month after last ECT. Here in this, you can see that equal means there is no worsening or improvement. Upward facing triangle means there is improvement. Downward facing triangle means there is worsening. So as you can see here, in almost all domains, there is improvement of cognitive functions. This is largely consistent with Semkowska et al. Meta-analysis. What about patient's perspective? There is a poor correlation between objective test results and subjective experience. Most patients who express subjective cognitive difficulties for some times, very few complain of specific retrograde memory loss. So subjective perception is more related to mood than the objective evidence. Now, there are clinical concerns with cognitive effects, which are, elaborate neuropsychological tests cannot be done. MMSE or MoCA can be used, but they do not address many cognitive aspects, which is the MMSE or MoCA can be used, they are brief, but they do not tap autobiographical memory, they do not tap subjective perception of memory, they do not tap relative perception of patient's cognitive abilities, and they include cognitive abilities which are not known to be disturbed by ECT. Hence, there is a need for ECT-specific cognitive batteries. We have developed such a battery called the Before ECT Recode, which includes subjective and objective measures. Retrograde antegrade memory is included, verbal and visual memory is included, orientation, sustained attention, working memory. These are the ones which are included in this. It has been validated in the Indian context. It takes about 20 to 25 minutes to administer. It is ideally done at the baseline and then after 3rd, 6th and 9th ECT. And individual domains are not important. There is nothing called total score. It is helpful for making clinical decisions. Recently, another set of researchers have come up with an even briefer cognitive assessment called the ECA, which covers all important domains. It is also sensitive to change as compared to MoCA. It takes only 10 minutes. This also can be used. And following this, we have now revised the before ECT record in an MD thesis, and our revised before ECT record takes about 10 minutes to apply. My take-home message at the end of this presentation is that ECT practice in India is different from that of the West. Ultrabrief-pulse ECT is promising in terms of cognitive safety, but its efficacy may be compromised, and it should be explored in indications other than depression. Ketamine is likely to inferior to ECT in depression. Ketamine anesthesia has very limited place at the moment. ECT in schizophrenia, it may expedite improvement, but its role in TRS, that is treatment-resistant schizophrenia, particularly clozapine-resistant schizophrenia, needs more definitive evidence. And cognitive adverse effects of ECT are mostly transient, and we have clinically usable tools which PG students can quickly use.
For your wonderful and informative presentations. Shall we take only 2 questions?
Yes.
Can you choose the questions from the chat box, Dr. Jagadisha?
Yeah. How often are we practicing brief or ultra brief pulse ECT in NIMHANS? Is the efficacy lesser? Should we prefer conventional ECT over brief pulse ECT? Okay. Now, conventional ECT, if you mean sine wave ECT, the answer is no. Sine wave ECT should not be used. So if you say that sine wave ECT should not be used, then brief pulse ECT becomes the conventional ECT. Now the conventional ECT is brief pulse ECT, and ultra brief ECT is the new one. So from what I presented, ultra brief ECT may be useful to spare cognitive effects, but it may be slightly less efficacious than brief pulse ECT. In NIMHANS, we use both ultra brief ECT as well as brief pulse ECT. Ultra brief ECT, we use it only for elderly patients for unilateral ECT. For the rest of the people, we use bilateral brief pulse ECT. I hope I have answered your question. Kindly share ECA tool. ECA tool, I will send it to the organizers. They can use it, but I'm not sure. I mean, ECA tool is not Indian one. It is an American one. I'm not sure whether you can use it without the permission of the original authors. Anyway, I will share that ECA tool. But we have developed a new tool which is very similar to ECA tool, which we can share it with you. What is the difference between ECT with APD antipsychotic drugs versus APD only over a long-term period in 295? I didn't understand that. Okay, ECT is always given along with antipsychotics for schizophrenia. So it is still not clear whether ECT is more useful than antipsychotics alone, but it appears that adding ECT to antipsychotics increases the speed of response. The final response may be the same. It may help in expediting recovery. It is not still clear whether ECT is more helpful in clozapine-resistant schizophrenia. We have to wait for the results of our study. What is the response for ECT and clozapine in catatonic schizophrenia? ECT alone is helpful. Clozapine alone in catatonia is doubtful. Paneer, I think we can.
Yeah, thank you, Dr. Jagadisha. Thank you very much. Sir, Gopal Goyal, sir, can you give your comment?
Sir, good morning, sir.
Yes, sir. Please give your comment, sir. Gopal Goyal, sir.
Hello?
Yes.
Yes, sir. Yes, sir. You can proceed.
Sir, I thanks the esteemed speakers and participants. I would like to thank for your thought-provoking discussions on today's webinar on the electroconvulsive therapy. As we conclude that, as already Sir has told about the very important take-home messages, Along with sir, I also want to summarize some of the take-home messages. As your presentation, sir, uh, very easy to understand for all the audience, and it has highlighted the many points, particularly the brief pulse ECT is better in the efficacy but have a more side effects. And if there is a urgent response is required, then the brief ECT is better, and the ultra brief ECT is having a less cognitive impairment. If we regarding the ketamine versus ECT, there is a two different type of the study, which is that is ELECT-D study and the CAT ECT. But there is in the one study, there is shown that the ECT is better than the ketamine, and another study shown that the ketamine is the better than the ECT. But the reason could be to the different profile of the patient's setting and the nature of the illness. Overall, the ECT will be the standard treatment for the all the resistant patients or who are having a depression with the psychotic symptoms. Another important point was discussed by the sir is the ketamine anesthesia for the ECT. As sir has highlighted, the advanced there is no other extra advantage of adding ketamine in the as an anesthesia for the ECT, but maybe there is an advantage early during the ECT course, but the adverse effects are the more concerned, which are highlighted in the all the study, like the hypertension and the other side effects. Sir, another important point which was highlighted is the ECT in the schizophrenia. There is a lot of difference between the Asian or the Russian countries and the Western or UK. In the UK and the Western country, there is a very less number of schizophrenic patients are given the ECT, but in Asia or Russia, more number of the schizophrenic patients are given included in for the ECT purpose. Though there is a limited evidence suggests that the ECT plus antipsychotic is better than that. But if we think about the adding ECT into the antipsychotic, there is a more speed of response. Response is the fast in the first and the second week of the ECT, and the response will be sustained in the later part of the therapy also. Along with this, ECTs are, if you see about, there is a comparison between the ECT and the Clozapine. The ECT was better in the all instances of in the treatment-resistant schizophrenia than the Clozapine, but the result need to be considered as a caution considering the limitation of the studies. Thank you, sir, for your wonderful presentation. Thank you.
Thank you. Thank you, sir. I once again thank Dr. Sri Gopal Goyal sir and Dr. Jagadisha for sparing their valuable time. I thank my colleague Dr. Vasu also, and I thank all the participants for the patient listening and also ask multiple questions. The YouTube link is available in the website, East West Pharma website. If anybody want, they can contact us at the East West Pharma. I thank the sponsor East West Pharma. We'll wind up this session with the East West Pharma.
Doctor, for giving such a wonderful program, and I'm cordially extending my gratitude to Dr. Jagadisha Thirthalli from NIMHANS Bangaluru, has given a wonderful lucid presentation for the benefit of our postgraduates. And also thanks for Dr. Sri Gopal Goyal sir to attend as a chairperson who accepted our invitation and has given his immense inputs to the and also weightage to the program. And we are extend our gratitude to Dr. Panisalan sir as continuously giving us a program and as acting as a course director for this evolve. And also thanks to Dr. Vasuki also has moderated the session very well. So thank you very much. And our link is also available with the resource pharma. You can contact our field force and given in number in the chat box. And the winners will be rewarded with a certificate as well as a gift vouchers directly to you. Thank you so much, sir, and have a great day to all.
Bye.
Thank you all. Thank you. Bye.
Bye.
Thank you, sir. Thank you, Goyal sir.
Thank you, sir.